So Fermin, this is Dr. Sunil Arora. That's our head of the department.
Good.
Hello, Dr.
Hi,
Sanchez.
Dr. Arora. Thank
Good.
you for the kind invitation. It's a pleasure.
Yeah, it's a pleasure for us that you have joined. It's very kind of you that you agreed to deliver a talk. So
okay,
we look forward.
not a problem. Yeah, not a problem. I'm glad to have met Aruna throughout this ISCT program. So it's always exciting. The good things have been going there, but unfortunately, it's difficult to move right now. But this would have been even nicer.
It would be very nice to have you personally here.
Chandigarh is such a beautiful place that worth visiting. So
yes, it is quite nice to stay here. Yes. So how are things in Spain as far as COVID is concerned?
Well, we have a big wave of Omicron, but since we are one of the European countries with the highest vaccination rate, so although we have many cases, most of them they were mild. So immunologists here are saying that everybody has received sort of a fourth dose of vaccination with the Omicron because it was very mild, but it was very extended. So the main problem we have right now are those patients that are immunosuppressed, especially our hematological malignancies patients, and those who have not been vaccinated, but it's a very a small percentage of the population. So currently, for instance, our department, we have around 12 patients immunodepressed in the COVID area, although they have mild disease, but sometimes some of our patients are really immunodepressed and they have like persistent PCR, and it's hard to discharge those patients from the hospital. But the wave went very well. So I would say around the turn of the year, many people get infected, but with small impact at the hospital level.
Yeah, it's same here. Actually, in India also, although vaccination is now in 2/3 of population, which is also huge, but it has been very mild. Like as far as disease severity is concerned, although the number of people who got infected was very high, but those who reached the ICU or those who actually needed the oxygen supplementation was low. So that's how the things have gone all over the world. You know, wherever you see, Omicron has not caused very severe disease. So whether it is because of the underlying immunity which is generated because of Delta and earlier infections or vaccinations, so whatever you say explanation, but or you can say it's a bit milder on the side of virulence. So
absolutely.
So we are almost on time now. So if you allow me, I'll introduce you and then we can start with the talk.
Okay, that's perfect.
All right. Okay. So good afternoon, everyone who have joined for this very special lecture by the distinguished speaker, Professor Fermin Sanchez-Guijo. Is that right?
Yeah, perfect.
All right. So this is a part of our lecture series. So in a row, we have been holding these talks, and Dr. Fermin has been very kind to have accepted our invitation to deliver this talk. He is Director, Cell Therapy Area and Head of Hematology Department, IBSAL-Hospital, Universitario de Salamanca. So the Department of Medicine, University of Salamanca in Spain. Dr. Sanchez has interest in cellular therapy and regenerative medicine. He's working as PI or collaborator in over 43, number of research grants That's a huge, and I think humanly, I don't know how much time he can devote to each one of them, but it's amazing. So the few of these biggies are Horizon 2020. He is actively involved in 61 clinical trials in malignant blood diseases and cell therapy, which is again tremendous work, you know. So I think he's working 24/7. Only then he can look after one of these. So he has authored more than 110 indexed publications with citation 4,500 citations with that index of 37. He's also editor of various journals, namely Stem Cell International. So it's a pleasure, Professor Sanchez, to have you with us. You have decided to speak on role of mesenchymal stem cells in allogeneic hematopoietic transplant setting. So over to you, Professor Sanchez. I'll request everyone who is present, if they have questions, please keep putting that in the chat box, and we'll take it at the end of the lecture. So, Professor Sanchez, over to you, please.
Okay, thank you so much, Professor Arora, for your introduction and your kind words. For me, it's a real pleasure to be here talking to everybody who is connected. I must say that this is an initiative of Dr. Aruna Raka. She is involved in one program that is the mentorship program of the International Society of Cellular Therapy. I'm currently the Vice President-elect of ISCT for Europe. We have very interesting discussions together with Aruna and another mentees once a month. So she kindly invited me, and it's my real pleasure. It's fun what Professor Arora said, that well, if you do many things, there's a problem, because I hardly get to sleep. So one of the things that the people say to me, well, you're doing a lot of stuff every day, but the problem is that sometimes for some people it's hard to get to sleep. So I try to work a lot of time during the day, and also try to keep some time for family. But it's interesting the way we do, like teaching, doing research, and also seeing patients is a wonderful occupation. So I'm really happy right now to be involved in a lot of stuff. So if I can share that we tried and worked perfectly, just need that you confirm that you're seeing the first slide and you hear me properly.
Yes.
If so, as Professor Arora said, I'm trying to explain or to give you my vision on the role of mesenchymal stromal cells in the setting of allogeneic stem cell transplantation. As a hematologist, I've been involved in stem cell transplantation, and we incorporated the research at the clinical level and at the preclinical also for treating some of the complications of allogeneic stem cell transplantation. Although we have a program of regenerative medicine, the primary activity and the reason why we started is to develop these mesenchymal stromal cell products to treat especially refractory acute graft versus host disease patients. So this is some support that I received from pharmaceutical companies, but none of them are affecting the current presentation. And what I'm going to do in the next minutes is to go to this outline, some overview on how the cell therapy in the setting of stem cell transplantation is currently now, at least in Spain. I will make some initial comments on the role of MSCs in transplantation, and then I will focus on the data that other groups and ourselves have generated in the treatment of graft versus host disease and also on post-transplant cytopenias, because this is a good example on how MSCs could also be useful for other immune-related disease. And if we have time at the end, I will also try to give you an overview of some other recent investigations that we're doing with extracellular vesicles that are derived from mesenchymal stromal cells, but only if we have enough time there. So this is a slide from a manuscript of Christian Chabanon, a very good friend and colleague from France, saying that hematopoietic stem cell transplantation is really a beautiful clinical platform to develop additional forms of cellular therapy. So it's clear that the first cell therapy treatment, and we're treating many patients with hematopoietic stem cell transplantation, but within the setting of stem cell transplantation, we've developed mesenchymal stromal cells to treat GVHD. We've developed specific T cells to treat some infections, diseases. Obviously, the CAR T cell world has started through the donor lymphocyte infusion. So many developments of additional forms of cellular therapy have raised within the context of hematopoietic stem cell transplantation. I'm sorry because some of this is in Spanish, but this is the data of how many patients are treated in Spain with either in the transplant setting with mesenchymal stem cells or CAR T cells or other forms of cellular therapy. And as you can see, there is around 50 patients per year treated with mesenchymal stromal cells in Spain. There are also a lot of CAR T cells. This was 2019. And if we go to 2020, there's a big increase in CAR T cells as everywhere, but also mesenchymal stromal cells are treated for a number of patients, especially in the for treating acute GVHD. This is a summary of some of the clinical trials that we've been performing in the last few years in our institution using mesenchymal stromal cells. In the first two lines are in the hematopoietic stem cell transplant setting. I'm going to touch on some of these during my presentation today for treating acute GVHD and cytopenias, but we've also been involved in a number of trials treating fibrosis of the lung, some problems of lung surgery, perianal fistula, and there's a commercial product developed in Spain and now approved in Europe, orthopedic and traumatologic problems like spinal fusion and osteonecrosis, osteoarthritis, high limb ischemia, and lately during the COVID pandemic, we've also treated some patients with mesenchymal stromal cells for severe COVID to try to reduce the inflammation. So as you all know, most of the audience will know, mesenchymal stromal cells currently are an advanced therapy medical product and has to be produced in good manufacturing practice facilities that need to be approved by the regulators, the medicinal regulators, the EMA or the Spanish Medicines Agency. And we've been changing our production protocol throughout the years. We started with fetal calf serum, then we moved to autologous serum, and lately we've been working in the last few years with platelet lysase and other basic methods. And what we try to do is from 50 mL of bone marrow, we develop our scheme of treatment for immune-based diseases. That is, sorry, let's go back. That is 1 million per kilogram per dose, and we try to give the first 2 doses within the first week, days 1 and 4, and then we give 2 additional doses on a weekly basis, day 11 and day 18. In the allogeneic stem cell transplant setting, probably there are like 3 big areas where MSCs may have a role. The first one is the treatment of graft versus host disease, and this is due to their ability to immunomodulate activated immune cells, especially T cells, but also B cells, dendritic and NK cells. Mesenchymal stromal cells are the precursors of bone marrow niche cells, especially osteoblasts, and they have a role, and we will see their potential role in engraftment. And also they release a lot of growth factors, so they're also may have a role in other complications of hemorrhagic cystitis and others within the allogeneic stem cell transplant setting. There's one interesting thing, and we investigated along like 10 years ago, if we could use autologous mesenchymal stromal cells or allogenic for our transplanted patients. And we studied at diagnosis how mesenchymal stromal cells from patients with hematological malignancies were. And we soon realized that these mesenchymal stromal cells had functional abnormalities, but also genomic abnormalities. So first thing is, first conclusion here is that if you want to use mesenchymal stromal cells for treating complications after allogenic stem cell transplantation, you have to use allogenic cells, because if you use autologous cells, those cells remain are from the recipient, and they keep genomically and functionally abnormalities, and therefore you cannot use them. Another commentary I would like to make is regarding the immunomodulatory ability of these cells. When you put these cells in vitro with activated cells from the immune system, the response is always inactivating or modulating the activation, and they try to foster the expansion of immunomodulatory cells. So when you incubate MSCs with mononuclear cells, you get an upregulation of regulatory T cells, you get M2 immunomodulating macrophages, you have B2 B cells. But one important thing is that to be able to become immunomodulatory, these cells need to be administered in a pro-inflammatory environment. So when we have tried to use mesenchymal stromal cells as preventive, to prevent the development of acute GVT, we haven't been so successful. Whereas if you use mesenchymal stromal cells when the graft versus host reaction has been already developed, these cells become activated and increase the release of immunomodulatory factors. So this is another issue that has to be taken into account. So let's move into the results of the use of mesenchymal stromal cells in refractory graft versus host disease. This is the area where most of the information is available. I like to show always this slide with the pathophysiology of graft versus host disease. This is a reaction that is induced by tissue damage, probably because of the conditioning regimen. The microbiota is also important, and obviously the immune system. But since we have these immune cells from the donor, and we have damaged tissue in the recipients early after the transplant, there's obviously the presentation of epitopes to these T cells that become activated against the skin, against the liver, against the gastrointestinal tract, but also against the hematopoietic system, because most of the stromal cells from the bone marrow remains being from the host, not the hematopoietic, but the stromal cells. So this is the first clinical case report of a patient treated for refractory GVHD with mesenchymal stromal cells, and this was published in 2004 by Katarina Leblanc, also a good friend. And it was a child that developed intestinal and hepatic graft versus host disease. So you have elevation of bilirubin here, and you have number of stools per day. You can also grade the intestinal GVHD throughout the milliliters of diarrhea, but the number of stools is also acceptable. So this patient developed intestinal and liver GVHD and was treated with standard treatment at that time, immunosuppressive, cyclosporine, prednisone, infliximab, etc., but eventually relapsed and received a first dose of mesenchymal stromal cells, and then responded in both organs, but eventually relapsed and received a second dose and then remains in response. So this was I remember very well how this impact in the transplant field. So many clinical trials were developed, phase 1 and phase 2 in this setting, and which is probably one of the biggest trials that was developed at that stage, again published in Lancet in 2008, 8 years later, where a number of children and adults with refractory GVHD were treated with mesenchymal stromal cells, and the results were pretty good. I mean, these patients had around 60%, 70% of response, overall responses, with maybe half of them complete response of graft versus host disease. But the interesting thing is that those patients that achieve a complete response, compared with those that didn't achieve a complete response or just a partial or no response, they have a clear advantage in overall survival. And this was seen by many trials. So what did we do at that time? We developed in the Spanish group a first clinical trial, phase 1 and 2, trying to use cells instead with fetal cal serum. That was this European trial, with autologous serum, trying to avoid animal material within the production. And we observed more or less the same, as around 70% of responses in acute GVHD and the same for chronic GVHD. But we realized in this trial that we needed some additional doses for some patients. And also that we have to cryopreserve the cells and we have to have everything ready. Because what we did at this stage, we're starting with haploidentical MSCs, is trying to prepare the cells for an individual patient, and we were too late in some of them. So we developed a second clinical trial in which we use platelet lysate, and we established this 4 doses scheme that I've showed you before. So we improved the production and also the way we distributed the doses. And we observed, again, around 70% of responses. Half of the patients have a complete response. Some of them relapse, but those who achieve a complete response, again, have a significant advantage in terms of overall survival. So this has been also, the same results have been obtained by many groups. So there's a clear correlation in the phase 2 trials between the achievement of complete response to mesenchymal stromal cells and overall survival. And there's no correlation for those patients, obviously, who do not achieve a complete response. So then the next step, and this was very clear, had to be phase 3 trial. And this is also a very interesting story from the scientific and clinical point of view. There was this company, American company, that was Osiris, who developed a product, MSC product, based on bone marrow mesenchymal stromal cells. So this product was tested in a clinical trial, and this trial was presented in 2010 in the American Society of Transplantation meeting, the what we call bone marrow transplant tandem meetings. The problem with this trial is that the primary endpoint of this trial, the PGIMER product, was not significantly different to a standard treatment. So the trial was negative. But if you looked at those patients that have only liver and gut involvement, there was a significant benefit of the treatment with mesenchymal stromal cells. But in this trial, they included a lot of patients with only a skin graft versus host disease. And skin graft versus host disease is very simple and easy when it's the only organ to be treated with any second-line potential treatment. So that was probably the reason why this trial, the overall responses were not significant. But you know, when you have a phase 3 trial and you are a not big pharmaceutical company or a small biotech company, you invest a lot of money in developing a phase 3 trial. If the primary endpoint, and in this case was overall responses at day 28, and you don't meet your primary endpoint, your program is at risk of disappear because the FDA in this case would not approve the product by any chance. So unfortunately, they closed the program. They never published it for 10 years. And the program was transferred to an Australian company that was Mesoblast. So eventually, this trial was published a couple of years ago. And again, obviously, no differences between the cellular therapy arm and the standard treatments. But interestingly, there was significant improvement for a subgroup of patients, liver, pediatric patients, of those with the highest risk disease. So in the design of new clinical trials, everything from this trial has been incorporated, all the learnings. And this is, for instance, a clinical trial in which we participate in. The results are not available. And this is part of a European trial that has been funded by the European community. So in this trial, as I mentioned, we have tried to learn lessons from the Osiris trial. And we included only patients with gut or liver involvement and those with severe disease, but not those patients that have only skin involvement. We have a uniform comparative arm, the one with the placebo and the one with mesenchymal stromal cells. And we have developed this trial. It's a very interesting one. It has a lot of biological background behind, but we are really waiting to see how it has been working, and the results will be probably available soon. And this is an interesting reflection of a very good friend of mine, Jacques Galipeau. Is probably Jacques is the top guy in the world in the MSc field. He's coming to Salamanca late this month in February. I have invited him, and we're fortunate to have him. He's the current president-elect of the International Society of Cellular Therapy. And in this review in Cell Stem Cell, he and Luc Sensebe were discussing how important is in cellular therapy to really optimize the design of clinical trials. And they've shown how changing the primary outcome, changing the population to include those who really benefited most of the cells in the phase 2 trials. This is the way to design new phase 3. And when you do this, you get a higher chance of approval of your product. This is the work that has been presented by Mesoblast in some of their trials. In this one, they obviously have a different primary endpoint, including only those patients really who benefited, and they have significant responses for the mesenchymal stromal cell arm. And they are trying to get approval from FDA. It's not going to be. This is a comparative study with a historical control, so they have been having problems with FDA with this. But it's all obviously they are claiming there are some problems in terms of ethically to include a placebo arm in pediatric trials. So we can discuss this after the presentation if you want, because these data are interesting. And if we go to real world, And this is again one of the largest series of patients that was published last year. There's a big improvement in overall survival again for those patients who respond. And this is more than 300 patients treated in real world in Japan. So how do the mesenchymal stromal cells work? And this is another area of big interest in this field. We know that this is an expansion of regulatory T cells. This is clear from the very beginning. We started to use these cells, but probably the big approach here has been made by Francesco Dazzi group in London. Also, we have been collaborating with Francesco for a number of years, and they showed that when you put mesenchymal stromal cells with serum from the recipient, either in animal models and samples with patients, in those cases, when you have apoptotic MSCs, those patients tend to respond. And the working hypothesis that they have is that these cells that become apoptotic within after the infusion, they are phagocytized by macrophages, and are those macrophages that move and switch to an M2 immunomodulatory phenotype, those that do the immunomodulation within the tissue. So we've learned from this work on, and many people are now focusing on the effects of macrophages, this interesting idea of apoptotic MSCs and those patients who in this mixed culture, when incubating with serum, become apoptotic. Those patients are those who really have a higher opportunity and higher chance of responding to the cells. So what about what I like to call bone marrow GVHD? So this is, again, an interesting idea. After the transplantation, after the hematopoietic stem cell transplantation, we replace the hematopoietic system by the hematopoietic system of the donor. But the stromal cells that remain in the bone marrow niche within the bone marrow remains a host in origin. So they are a target for the T cells of the donor in the setting of graft versus host disease. And it's very interesting that in some animal models of graft versus host disease, this line of osteoblast is depleted. So this also very interesting that we can treat those patients with allogeneic mesenchymal stromal cells and see if these cytopenias can also be improved. So we've treated a number of patients with cytopenias, with thrombocytopenia and with neutropenia after the allogenic stem cell transplant, those patients that didn't respond to a standard treatment like immunoglobulins, steroids, or rituximab, and some of these patients do respond to sequential doses of mesenchymal stromal cells. And we have developed also a clinical trial showing that those patients that really with cytopenias after the transplant that respond to mesenchymal stromal cells also have a significant benefit in their survival. So again, and it's interesting, we've seen that mesenchymal stromal cells work in different ways. Cell-to-cell contact, the secretion of soluble factors, but also through the exchange of extracellular vesicles and even by nanotunnels, exchanging even mitochondria. So there was this very early experience of treating graft versus host disease with exosomes derived from mesenchymal stromal cells. And this was a German group. I had the opportunity to talk to Cordelas in one of the IACT meetings. So this was very interesting because from a regulatory point of view, the use of extracellular vesicles is easier and have some advantages over the use of mesenchymal stromal cells. So in the last part of the presentation, I will touch a little bit on that, on the role of extracellular vesicles. There are different kinds of extracellular vesicles, and we will go through in a few slides. Some of them are developed through the endosome apparatus, and they are called exosomes. Some of them are released from the membrane and are called microvesicles, but the general term for all of these kind of vesicles are extracellular vesicles. And as I mentioned, there's a number of advantages that extracellular vesicles derived from MSCs may have over the cells. They are not advanced therapies, medical products, according to the FDA and the European regulations. So there's probably within the group of biological drugs. Since they don't have a nucleus and the ability to replicate, in terms of biosafety, you don't have this potential of carcinogenesis or malignant transformation. They are very stable and easily stored and frozen. They can be frozen for many times. They are able to cross the blood-brain barrier, and this may be interesting for some applications. And from a scale-up and industrialization point of view, it's very easy to immortalize mesenchymal stromal cells and give rise to, in bioreactors, a very uniform type of extracellular vesicles that can be produced and commercialized in the future. So it's an interesting field that we are starting to work a little bit on these vesicles. There's a lot of issues right now in this field. First one is the classification, and you can have different types of extracellular vesicles depending on the size, depending on the biogenesis. As I mentioned, the microvesicles are derived from the membrane, the exosomes are derived from the endosomes. There's a different content. The selection and production methods are different. But they contain lipids, a lot of bioactive proteins, microRNA. So it's a real mess to analyze different and compare different works. But this is more or less the structure that the extracellular vesicles are. And as I mentioned, many different ways of isolate them, and each one of these methods have their own issues, have their own problems, their advantages and the limitations. Just wanted to let you know that there's a lot of stuff in terms of isolation and production of these vesicles. We tend to use the ultracentrifugation. That is the method that most people use. Can be also the ultrafiltration, and I don't want to get into that. There's an active interest in the scientific societies to really classify and uniform the way all the works done with extracellular vesicles are presented. And there's an international society for extracellular vesicles that is working hardly in that. Even in the International Society of Cellular Therapy, there's a big interest group of working group on vesicles. And first thing we try to do, and this is a work that has, this is an old one of the first in 2016 that we produced. We were trying to see if we could identify vesicles derived from MSCs using the same surface markers that we know that are positive in the stromal cells. And in this work, we characterize by flow cytometry the extracellular vesicles that are really small, and we do the electron microscopy, the Western blots, and what is called nanoparticle tracking analysis to measure the size. And we observed that obviously, as we expected from the beginning, these vesicles derived from MSCs, we can identify them because they have the markers. And we've been using these vesicles to try to improve the engraftment. And this is a manuscript that came a couple of years ago that I'm going to explain to you how we approach this issue of trying to increase the hematopoietic engraftment after transplantation. What we try to do is to incorporate extracellular vesicles derived from mesenchymal stromal cells into CD34 hematopoietic cells. We knew, and we published, and we and others some years ago, that if you co-inject mesenchymal stromal cells with CD34 in an animal model of xenotransplantation, hematopoietic xenotransplantation, you're able to increase the hematopoietic engraftment due to the action of the mesenchymal stromal cells. So the question here was, instead of using the cells, the mesenchymal stromal cells, why don't we incubate the hematopoietic cells with the extracellular vesicles derived from mesenchymal cells and see if these CD34 hematopoietic cells have an advantage in terms of engraftment compared to those CD34 positive hematopoietic cells that have not been incubated with the extracellular vesicles. That was the hypothesis. So we isolated the vesicles from the mesenchymal stromal cells, we characterized them, and we incubated our cord blood hematopoietic cells with these extracellular vesicles derived from the stromal cells for 24 hours, and then we explored the changes induced in the CD34 positive cells, and we obviously performed in vitro and in vivo functional analysis. That was the interesting thing for us. So what we see is that obviously we characterize the vesicles, and they were able to incorporate into the hematopoietic cells because we labeled the vesicles with fluorescent dyes. And there was a number of genes that were changed in the hematopoietic cells after the incorporation of extracellular vesicles. Most of them had to do with survival, with hematopoietic determination, and some interesting signaling pathways. So the global idea was there was an increase in anti-apoptotic genes and a decrease in pro-apoptotic genes. So the viability of the hematopoietic cells was higher, and this is interesting in terms of engraftment. So we have more viable cells that they have higher expression of adhesion molecules. So this is also interesting for the engraftment. And when we did the clonogenic potential, these hematopoietic cells that have been incubated with stromal cell-derived vesicles have an increased clonogenic capacity. They were able to augment the number of hematopoietic colonies, and the in vivo data showed that there was a significant improvement in the engraftment for those cells that have been incubated with extracellular vesicles in our animal xenotransplantation murine model. So this is interesting, and I think in the next few years we will hear a lot of stuff on the role of mesenchymal stem cell derived extracellular vesicles. And we're currently working in some aspects of extracellular vesicles with other groups of the Spanish Cell Therapy Network and the Spanish Advanced Therapy Networks. We've seen how the extracellular vesicles derived from MSCs are able to do this immunomodulatory activity. They are able to decrease the activation of T cells when they are stimulated, and this may have to do also with the dose of the extracellular vesicles. A higher dose, greater reduction in the proliferation rate of the T cells. We are evaluating their in vivo role to reduce inflammation in some animal models. There's a standard animal model of early inflammation by the injection of lipopolysaccharide in the food pad, and again the vesicles are active there in reducing the inflammation. And there is a group in Spain that is working with Robert Sackstein, that was previously in Harvard University, and now Robert is in Florida. And they've shown that the fucosylation of the mesenchymal stromal cells is able to increase the engraftment to inflammation sites. So we wanted to assess if the extracellular vesicles derived from fucosylated stromal cells are able to increase their properties in vitro and in vivo. So the vesicles become fucosylated also, because most of them come from the membrane. And we've seen that when you infuse extracellular vesicles derived from MSCs that have been fucosylated, you have an advantage in survival when you treat animals with graft versus host disease with these extracellular vesicles. And the effect is higher if you use vesicles that have been derived from stromal cells that have been fucosylated, because they are able to, you have a higher number of vesicles that go to the damaged tissue compared to standard extracellular vesicles. But again, in this work, we've shown that the vesicles are active in reducing the inflammation and the immune activation in vivo. And with that, I think I may conclude. Looking forward to the discussion with all of you right now. So this is not my lab. This is no, it's not the cell therapy lab. It's just the whole hematology department with not only clinicians, but also technicians and pre and postdoc investigators. So it's a big group. It's involved many people working in hematological malignancies, but also in cellular therapy. But the cell therapy is a small group. And this is my last slide. This is our new hospital. And we have the old one here, so we're gonna expand all this area. Is our hospital. We have different buildings, and this is the new one. We have a cancer research center, and then we have the faculties of the medicine, the pharmacy, biology, nurse, physiotherapy, etc. And this is the old university building in our university. Salamanca University is the oldest university in Spain. Is one of the 4 oldest universities in Europe. It was founded in 1218, so that's more than 800 years ago. So we celebrated in 2018 the 800th anniversary, and it's a beautiful town to visit also. So all of you are always welcome to come if there's the chance in the future. So with that, I would like to finish. I'm really ready for any interaction and questioning with all of you. Thank you very much for your patience listening to me, and I'm happy to move to the discussion.
All right. Thank you very much, Professor Sanchez. It was a very, very interesting talk, and I'm sure, and it was given in such a simple language that most of it is understandable. No.
Thank you.
So even to the beginners or those who are looking at answers, I myself have been working on mesenchymal stem cells, and the questions always arise when we sit in the regulatory meeting and we are told that allogeneic mesenchymal stem cell therapy is still not in sight because of many regulatory inhibitions, because the data is not sufficient to answer those questions. So we always feel that we should be given chance to do a lot of clinical trials using mesenchymal stem cells. As you said, that mesenchymal stem cells have more than their own, cellular therapy. They actually change the endogenous mechanism. They induce endogenic mechanisms to start repair, to do so many things. As you have said, that these are the cells which when become apoptotic, they are taken up by the macrophages and they convert from M1 to M2 type. So that's a very interesting mechanism for an immunologist like me to understand that, okay, that may be one of the major mechanisms how it can do the immunomodulation and change the scenario, because we have tried to use these in rheumatoid arthritis, the rat model, and we have shown really good results, but people, have questions, how come the mesenchymal stem cells, they change the behavior? So I was always saying that there are endogenous mechanisms, but this interesting finding that it converts from M1 to M2, it also gives us all inflammatory disorders, wherever there are degenerative changes, these can help in that. So then you also showed that there is improvement in, cytopenia. So you can think of so many infections, diseases, other diseases, even cancers, where the cytopenia is the major cause of, many problems. So cytopenia, if they can improve cytopenia, is another very good one. And then, of course, the vesicles, extracellular vesicles you have shown, it improved the engraftment of hematopoietic stem cells, which is really, really interesting finding, that they take up these extracellular vesicles derived from the mesenchymal stem cells, and then it improves the engraftment of HSCs. So that is very interesting. And I really marvel that this is the amount of work, and we have to look for those opportunities when we can have you here with us for personal interaction, one-to-one with the students also, so that they can be encouraged to take up more of these kind of projects. So we have a couple of questions in the chat box.
Okay.
And no wonder they are one from Dr. Aruna Rakha itself. So Aruna is trying to say the same thing which I said. She says very insightful talk, and I'm amazed by the number of MSCs. You have shown that you have to give so many. You can give so many injections, like 8 times in 4 weeks, which brings in a huge number of these mesenchymal stem cells have to be infused. So how do you culture expand them, and do they go beyond 4 passages? Because what we have learned is up to 4 passages these cells, they are good, but after that they lose their efficacy as far as immune modulation or maybe even regenerative capability is concerned. So what would you say about that? How do you expand those numbers?
Yeah, that's a very interesting question. What we normally do currently, we try to get between 50 and 100 mL from bone marrow, and currently trying to approach to be close to the 100 mL. And in the GMP facility, we work with cell stacks, these piles of plastic chambers, and we try to expand those with alpha mem and 5% platelet lysate. With 100 ml bone marrow, we get, after 2 or 3 weeks of culture, the dose we need for 1 patient. So we try to have the slots of 4 million cells per kilo for a standard 75 kilogram subject. So we use not 8, but 4 doses for patients. So what we do is that we try to administer 1 milligram per kilo per dose. So that's the 4 million MSCs per kilo total dose. So each dose is 1 million per kilo. So this is around 75 million cells that we give for each dose. And we pretty, are pretty fine with that for most patients. And we never get over passage 2. We totally agree with that. We have never used cells in passage 3 or passage 4. It's probably they are less effective. We don't want to take any risk of senescence, or we haven't seen any cytogenetic abnormality. We do arise to see we normally do CGH arise in our cells, and we have no problems in terms of biosafety, but we never use cells more than 2 passages. So if we don't have enough cells after we passage, what we do is we cryopreserve what we have. And then if we have 1 million per kilo, if we have 2 million, whatever, we try to keep everything, but not try to surpass this level of passage through. So I would say what we normally, it's very important, the donor. The donor is essential. So what we try to do is to keep young donors, and we do the same analysis that we do for allogenic stem cell transplant patients. So we interview the donor. We try to use 20 to 40-year-old donors that are absolutely healthy, no comorbidities, no treatment with any drug, etc. And they are normally involved in the allogenic transplant setting. The donors are the brothers, the friends, or the parents, or whatever of patients that receive the cells. So they are highly motivated. But the donor is very important. If you have 100 ml from bone marrow or one of these good donors, it's easy that you get 4 million per kilo total of the 4 dose in a couple of weeks or 3 weeks of expansion in the GMP facility. But I totally agree that we shouldn't employ cells over passage 2 or 3. We've never used more than that.
So, Dr. Sanchez, you say that the donor is very important because you want to isolate them from the bone marrow. But the mesenchymal stem cells we can isolate from many other, sources like, umbilical cord. We have done very nicely from umbilical cord, and that's a discard tissue, and we bring it and we use that, Watson's jelly to make. So what do you think? They will be different as far as efficacy is concerned from the bone marrow derived, or what?
That's again a very interesting question. I'm very in favor of Barton's jelly mesenchymal stromal cells. But the problem is that each one of us has to adapt to what we have. We don't have a cord blood bank in our institution or nearby. There's a big group in Barcelona that has all the cord blood donations throughout the Barcelona region. And they've been working a lot with Barton's jelly mesenchymal stromal cells. A few years ago, with one of our bioinformatic groups in our university, we tried to assess the transcriptomic profile of mesenchymal stromal cells that were derived from Barton's jelly, from placenta. That is also, the placenta is very interesting because they have a lot of mesenchymal stromal cells and adipose tissue. And when you compare at the transcriptomic level and all the series that have been published, obviously there's a signature for MSCs that all the cells have, but there's also a signature of the tissue of origin. So in general terms, those cells that are derived from placenta and from Barton's jelly, they are more immature, they have higher proliferative potential, and probably are something that they express some more immature genes, and this is very interesting to know, and obviously there's a big opportunity for cord blood banks to expand, since now the cord blood transplantation in the hematopoietic setting is not used at least in adults anymore because of the haploidentical transplants. But this is important that the cord blood banks move to exploit the ability of increasing their use of the cord bloods in terms of generating mesenchymal stromal cells. So I'm very in favor of Barton's jelly MSCs and also placenta-derived MSCs, because those are products that are obviously discarded after the birth, but you have to have the cells from the source, and we don't have it in Salamanca, although there are groups that are working with that and collaborating with them, and that the results are clinically they are comparable, but I think these cells are more attractive because they are more immature, they have a higher proliferation rate.
All right. So another question is from Dr. Anupam as well as Aruna. They say that whether the treatment with extracellular vesicles decrease the HSC number required, as this is major limitation in the HSC transplantation. So since you showed that they improve the efficacy, can we transplant lower number of HSCs which are, treated with the extracellular vesicles so that the engraftment is much better? So even lower number would be sufficient.
Yeah, when we started this protocol of preclinical work, the cord blood transplantation is the only modality of stem cell transplantation that had a problem in terms of cell dose. You know that when you use mobilized hematopoietic stem cells, or when you use bone marrow harvested hematopoietic stem cells for adults, it's not a problem. The limitation in the cell dose is strictly related to the cord blood. So we've worked in the work that I've shown that has been published only with cord blood derived hematopoietic cells, and for the cord blood, it's clear that this is an opportunity to expand the number of patients that could benefit, but only in the cord blood, because for patients that have a blood or marrow donor, it would be too expensive, this modification, because you have enough cells from the donor. But in the cord blood, it's an opportunity, and for it's not for Caucasian in Europe and in the States, because but for underrepresented population in the international registries, some of patients do not find a matched unrelated donor, and some of them do not have an haploidentical. So for those that are candidates for cord blood, this would be a potential approach to increase the engraftment and to be able to use less cells to warrant the engraftment. So I totally agree with the hypothesis. Yeah.
So Dr. Sanchez, that brings me to another question, that since you are talking about the donor derived, bone marrow MSCs, you have to isolate every time. Is there any commercial source, like there are companies now which make stem cells, mesenchymal stem cells, and they can just supply that? Have you tried those kind of from the commercial source as well?
Not. We've been offered to compare those, but we haven't get the opportunity to compare those. It would be obviously those that are commercially available would be same quality. The problem is some of them are derived for just one donor, and my question there would be how many passages those cells are undergoing, because they try to use a very few number of donors, and they do a lot of expansion to commercialize the same, let's say, batch of cells. So it's interesting that this is available, but it's different when you use primary cells from donors. You keep control absolutely on the cells. You know exactly the number of passages, and you know that you can rate the senescence, etc. So it's interesting if you don't have the ability to have them by your own, and it's interesting always to compare the products. So So this is something that we have offered to do it, but not that everybody is interested in comparing with primary.
So have you done the complete analysis of the cargo carried by extracellular vesicles beside some of these microRNAs and mRNA? Have you published that cargo?
We've done mostly microRNAs, and we have to do we have to perform some proteomics, but the proteomics are very difficult to interpret, and it's always difficult. So this has to be done really at high scale. The problem is that when you isolate vesicles with different methodology, even if you stimulate the cells to release the vesicles or not, every change you do within the procedure, I think it may have an impact in the content. So even the mediums, the size, everything has to do with mainly with the content. But these studies are mandatory. I mean, I think that once some product and stable products are going to be used in clinical trials, maybe just already developed by biotech companies, the content is essential. But I think what we know is from the analysis of the microRNA on some early data on proteomics, we haven't published the proteomic yet, is that there's high variability depending on the methodology you've employed to get the vesicles.
So in the end, we have another question from Dr. Alka Khadwal. It's almost related to what I asked you earlier. She says that for clinical use in steroid refractory GVHD, what is the process to procure MSCs off the shelf? So it's basically, she's talking about whether we can have from the commercial source always, what is the cost of it? And then she talks about, because if we have to get it cultured at a GMP lab, for clinical use, we have to have a lab which is GMP compliance lab. So it will take 3 to 4 weeks, and then most patients become very, very sick by that time. So how do you maintain that, synergy between these two?
That's also a very interesting question. This is what we did at the beginning in our first clinical trials, and it was a problem because, as you mentioned, some of the patients really worsened the clinical situation, and some of them were really ill at the time the cells were available. So we really understood that we have to have cryopreserved MSCs in advance from a third-party donor, and use the first day we feel, day 7 of steroids, when we see that each patient is not responding or it progressing to steroids. So very early, and the earlier you put the cells, the better are the results. So for these kind of programs, you have to have your MSCs allogenic, cryopreserved, and inject them as soon as you become aware that the patient is resistant. And we have seen exactly the same in COVID-19 disease when we treated patients that were at the intensive care unit under mechanical intubation. We published really early in 2020 in eClinical Medicine, a journal that is part of the Lancet family. We published one of the first series of patients treated with mesenchymal stromal cells in the world. So what we did there, and we realized that those patients that were treated very early after intubation were those who tend to respond better. Whereas if you treat with mesenchymal stromal cells those patients that had COVID-19 and have been more than a week already after intubation and mechanical ventilation, the results were really not as good as if you treated earlier. So the sooner you treat with the mesenchymal stromal cells is important, and the approach we've done from many years ago is to have them from third-party donors and cryopreserve the cells. And at the time the clinician needs the cells, he asks for permission to the national regulatory agency, and then we try to put the cells the same day or the day after, once we have the permission to use them.
So, Dr. Sanchez, we have short time now, but I'll take the last question. It's raised by Dr. Amit Arora, who's husband of Dr. Aruna. You know, he works as associate professor in microbiology. So he's asking, aren't the contents of microvesicles quite random? For example, the location where it buds off dictates the contents of the microvesicles.
Yeah, the content of the microvesicles, I would say, as I mentioned, is not rough. It's probably what we know is that the cargo that the cell put in the vesicle is selective. So if you compare the content of the vesicles and the content of the cell, it's different. So we don't know exactly yet why the cells put a number of proteins and a number of lipids or a number of microRNA in the vesicles, but there's probably variability depending on the stimulus, depending on the time, depending on the passage of the cargo. So at the beginning in our group, I was very reluctant to pursue a lot of research effort in vesicles because I was too skeptic in terms of because of the variability in the methodology, the variability in the vesicles. But I think it worth being explored, this approach, because I think that the interest of the field is also there. But I feel more comfortable with for clinical application today in 2022 with the cells, because I always tell my collaborators here, well, you know, the cell is the one who makes the vesicles, and the cell can be keeping on making vesicles for a number of days once they are infused, and the cell adapt. But the vesicles, I understand, I really understand that they are far more simpler and have a number of advantages in terms of regulator. But the cargo is selective but very variable, and we don't know yet how to increase the uniformity unless you have an immortalized mesenchymal stromal cell line, that you have the same immortalized cell line that gives rise to the same vesicles with the same procedure, and then you can explore clinically in clinical trials when you protect intellectually this product. And unless you get to that point, it's very difficult to compare different, even the donor may have an influence, so the cell, the time, everything may have the ability to induce variability within the content of the vesicles.
So what I believe is that microvesicle formation and release is a very active phenomena of a living cell. So it is not just release of certain things, haphazardly. So it's a very controlled phenomena. And once a cell is growing in culture, I agree that at different stage of growth of a cell, the microvesicle formation may be having different content, but overall, the cells, when they are growing, they release microvesicles. It's a very, very organized mechanism. So I don't think it is like budding off from one angle will have something else, and the budding from the other side will have different. So that's not. It's a very well controlled phenomena. So thank you very much, Dr. Sanchez. It was very exciting, very interesting talk by you, and it stimulated so many brains, and a wonderful interaction and discussion at the end of it. So I'm very, very obliged, and thank you very much. And we really look forward to having you in Chandigarh sometime, if COVID allows us now.
Okay.
So it'll be very interesting to collaborate with you and do some more things. And we would like to show what we are doing here. So thank you very much.
Thank you
And,
very much, Professor Arora, for the invitation. It's been my pleasure to discussing for an hour with all of you. I also think that the discussion was very good, and you know very well where you've been working hard and a very interesting data. So for me, it's been a real pleasure to be here, and obviously it would be a great pleasure to visit. So anytime this situation allows, it will be my pleasure to meet you in person for sure. So thank you for the invitation.
thank you very much. And